What happens if we flip the traditional way of sharing medical information to the wider population on its head? What happens if instead of letting algorithms or the zeitgeist of the moment order our social media feeds, we go straight to the source of clinical medicine and ask practicing experts what they see day in, day out, and give them an unedited platform to help disseminate practical medical information straight from the specialist. Okay, so we started recording. Hello, Monica.
Hi.
How are you?
I'm good, thank you.
Thank you for coming and thank you for agreeing to record. Would you mind giving us a quick introduction of who you are?
So my name is Monica Khanna. I'm a musculoskeletal radiologist and I'm currently working at Imperial College NHS Trust. That's where my consultant position is, and I work part-time NHS and part-time privately.
And I've prepped you a little bit, but I think you wanted, in your first response, which was what would you like to share with the general population, you want to speak about what radiology is, and I think that's a good place to start. What is radiology? Who are you?
Yeah, I think it's a good place to start because most patients probably don't know really what we do. We're actually trained doctors. Sometimes they don't know that we're trained doctors, and often we're sort of hidden away either in the basement of a hospital or in a dark room somewhere,
windowless,
tucked away. So often patients don't know what we do, but I actually believe that we're almost part of the engine of the hospital because we work with multiple clinical teams, not just, for example, Brinda, you're the sports exercise medicine consultant, but also orthopedic surgeons, well, particularly in what I do because I'm musculoskeletal, but we also work with the physiotherapists, the podiatrists, so we are very collaborative in our team. And we also work with A&E, we work with the inpatient, the medical inpatient consultants. So we generally, when you're busy working in a hospital, you can often know many of the patients within the hospital.
Oh, really?
Because you're doing a lot of their chest x-rays, their inpatient chest x-rays, or their routine hip x-rays. And we also, one of the beauty and one of the things I love about the job is the multidisciplinary team meetings, where you have a chance to actually discuss the patient care in a really holistic way, and you actually learn from it. So you speak to your clinicians and colleagues about the patient, and actually the patient benefits from that because they tend to get the best care if they're discussed at a multidisciplinary team meeting. So the radiologist, we do all the reporting of the MRIs, the CTs, X-rays, and then we decide maybe what is the next best steps, whether that be imaging or interventional procedures. So we might do ultrasound guided intervention or interventional procedures under X-ray guidance or CT guidance. So we also provide treatment.
Okay. So just from the patient's perspective, if they go into A&E and they have wrist pain and they get a wrist X-ray,
yes,
you'll get maybe a nurse practitioner, a junior doctor, or if you're lucky, a consultant looking at you, and they can quickly review the X-ray.
Yes.
But actually what happens behind the scenes and what a lot of patients don't realise is that often those X-rays are then re-reported by a radiologist. Is that correct?
Yeah. So they will be reviewed in A&E and then they will get a formal report by a consultant by the next day. So within 12 to 24 hours, you get a consultant report.
And that's true with chest X-rays and things like that.
Yes.
I think that's how my mum's lung cancer was picked up as well.
Yeah.
And then, or it might tickle you that often patients will say, have you had a look at my MRI?
Yeah.
And I'm like, this PC screen, which is suboptimal. But I've really got the best radiologist who is a real doctor behind the scenes to have a look at it on a proper screen. What kind of a screen is it?
High definition screen.
Yeah,
and
so
actually,
it's not comparable to computer screens.
No, and often when clinicians walk in and maybe come and speak to me when I've got my PACS machine up and my machine and the whole high definition screens, they say, "Wow, it looks so much more different on your PACS screen than it does down in clinic. I couldn't see that in clinic."
Exactly.
And actually, we often try. And
this is better than a trader setup. When they have like two computers side by side.
Yeah,
we're talking proper
high definition screens, which are they are fantastic. We're very lucky from the technological point of view. We have, as the radiologists, we've also ridden that technological revolution really, because our technology changes regularly, resolution improves, And often I actually get the MRI up in front of the patient before I see them for an ultrasound guided injection. I say, listen, I've looked at your MRI, and they can see I've looked at it, or then they sometimes come over and look at it if they want to.
Yeah. So just to also, because patients will often come up with their scans on like WhatsApp or saved on their telephone.
Yeah.
I mean, and I'm just like, no.
Yeah, that's
but you'll back
tricky.
me up on that, won't you?
Yeah, that's more
coming
tricky.
from the specialist. Okay.
Yeah, more tricky.
Okay, so well, that isn't, we haven't fully answered what you were going to answer. So what would you like to share with the general population? Because you wanted to talk more, not just about what radiology is.
Yeah, I thought one of the interesting things to share with the general population is the fact that imaging can pick up, can be almost pathognomonic for certain conditions.
What do you mean by that? Sorry.
So, for example, and what comes to mind is patients who have long-term stiffness in the back, and this starts young, for example, and they get back pain, they get maybe sacroiliac pain, lower pelvic pain, stiffness, morning stiffness, and they just accept it as being normal, or they cope with it. And actually it can be an early sign of, for example, ankylosing spondylitis, which I think is a real classic for imagers or radiologists, musculoskeletal radiologists, because we can pick up really soft signs for it on MRI quite early to suggest that they actually have ankylosing spondylitis. And we know, and we were discussing that, is that there is a lead time for diagnosis from beginning of symptoms to diagnosis. And it can be, sometimes up to 8 years, which is can really affect people's lives. And they really didn't know that there was something that could have been done about it. And whether they actually, didn't actually know what diagnosis they had. And it's not infrequent that they come in for hip x-rays, for example, because they've got hip pain now, but actually you see, for example, their sacroiliac joints fused. And it's a sign of sacroiliitis, and they've just missed that they've had this, or they've just taken those symptoms because they're slow and they're progressive. They just don't necessarily seek the help. And I suppose that goes with GPs as well. Sometimes GPs say, oh, your back pain will get better. But actually that is a great time to opt for early imaging.
Yeah, think about it at least.
And think about it.
The way that I classify it, at least for the patient, this probably oversimplifies things for us medics. But this is the general population question, is that you have, broadly speaking, mechanical back pain and then inflammatory back pain. And I deal with mechanical, the rheumatologist deals with inflammatory, and then it's sort of a sliding scale.
Yeah.
And sometimes you can sit halfway and then never really get a full-blown diagnosis because your bloods are never positive. You never really show much on imaging.
Yeah.
But you've still got that inflammatory flavour where you have a few flares a year. It started when you were young, under the age of 35, etc., etc.
Yeah.
But by the time they get to me, it's still important, I think, when you've selected those patients, to offer imaging, just in case you can capture some inflammatory lesions, because as you said, they're economic, as in, so it's telling you that there is some inflammatory condition because it's not a mechanical, like overload of tissue that's broken down because of overloading. So thank you for explaining that. So what would you like to share with your GP colleagues?
So I decided what to share with my GP colleagues is frozen shoulder. I mean, I think it's
my
increasing.
favourite.
It's an easy win. What I think about it. It's
because it's one of those conditions where you can actually treat and send the patient out happy.
Yeah, and they actually are happy.
Yeah.
And it's one of those things you can actually cure for them. So it doesn't recur. This is not rotator cuff disease, which can go on and then they may need a procedure. And I think that many GPs often, when patients present with shoulder pain, think rotator cuff disease, which is perfectly understandable and acceptable. But there's that other one, which is frozen shoulder, which I think presents quite classically, and you can almost tell when patients have it because they walk in the door and they look like they are not sleeping. And that's
the Monica side, is it?
Yeah, that's the Monica side. My two questions to patients when I think they might have frozen shoulder, before I've even actually put a probe on them, I say, are you sleeping at night? And I've had patients burst into tears because they say, no, I'm not sleeping, and then they burst into tears because it's so debilitating on the sleep, different from impingement and rotator cuff disease.
So true.
And then the other thing I always ask is, if you reach out for something unexpectedly, do you get sort of shocking, searing pain? And they're like, oh my gosh, if I do that, if I, reach out for something about to drop, 20 seconds of severe pain. I mean, then that isn't the same as impingement. And then you scan them, and then we can pick it up on scanning, either be that MRI or ultrasound.
Can I add something to that clinically?
Yes.
I mean, but and you can also watch my fabulous YouTube shoulder examination video, which explains, I think, nicely how you can diagnose rotator cuff tendinopathies, impingement, or some sort of restriction of capsular movement. Yeah. And I think for me, like, we talk about a range of motion and like external rotation reducing. So that's like when you're holding a platter out in front of you, and then you keep your elbows tucked into your sides, and then you pull your arms out away from midline. So you compare one to left. So, but also internal rotation changes. So when you're putting your thumb up to your bra strap around the back, sometimes you can see it, and I suspect that's a restriction in the capsule at different points. Yeah. So it's any restriction in range of motion. But often you can, if you've got a slim enough patient and you've practiced this enough, you can put one of your examining arms on the shoulder and ask the patient to completely relax. So you're moving it. So you're bringing the arm out into abduction. And usually you can feel the scapular rhythm kick in at about 90 degrees. So that's when you start to get the scapular rhythm going. And you can compare it to the normal side to know what normal is for them. And then for restriction in this inflamed capsule, which is capsulitis, adhesive capsulitis, you actually get the scapular rhythm kicking in much sooner, 45 degrees, 30 degrees. And so something's up. And often they'll have like trapezius trigger points, because your trapezius is compensating, because all of that extra movement that scapula is having to do, you're just overloading some other things. And you can rule out, as you said, the other tendinopathies or impingement. But often you can't even get that far if the adhesive capsulitis is full blown. Yeah, absolutely. Because they can't even get their arm up to do like a Hawkins, Kennedy, all these specialist tests. And as I say, go back to my YouTube video if you need to refresh. But yeah, it was exactly that. So once you've diagnosed it, for me, I'm like, we can give you anti-inflammatories if you want, but do you know what the best thing is? I send you to get a high volume injection with some steroids, so salty water and steroids. So that's why I send over to then radiology. Yeah. And that's when you take over.
It's very satisfying. Yeah. It's a straightforward procedure. It can be done under ultrasound guidance, so they're not having any ionizing radiation. They can just come in and have it and then go home. It's revolutionised really the number of shoulder surgeons doing capsular releases now, because we do them. Because
historically
they used to be capsular releases and they used to be surgery. Yeah. But now
under GA.
Yeah, they'd have to go under a GA. Well, now you can do it in your ultrasound room under local anaesthetic. Yeah. Can be a bit uncomfortable.
It's a heaviness.
It's the real heaviness. You're absolutely right. They all describe that heaviness.
But it's not a pain with the needle or anything like that.
No, it's just the fact that you're trying to push against a capsule that doesn't want you to push against it. But I always say to the patients after, the first thing that tends to come back is their sleep. Then the pain starts to resolve. And then the movement starts to come back. And it sort of tends to go in that order for many patients. And that at St Mary's Hospital, we do routinely 2 weeks apart. We book all patients for that. That's our standard care.
Oh, okay. So that's changed since I was...
at Imperial. And the reason being is that we know that one often doesn't completely solve it. And they may get better to about 80%, but then they tend to slip back a bit, or they start to slip and their symptoms start to return. 2 really tends to knock it on the head at that short interval. I mean, we've done an audit on it, but we haven't done
why 2 weeks? Because that's interesting.
I know, it's interesting. It originates from an audit we did a while back, One of my colleagues actually did it, and she looked at 1 versus 2 versus 3. It's like the Goldilocks porridge. It's 2 is 2. There's no difference between 2 and 3, but 2 is better than 1 in terms of symptomatology and returning of the symptoms. Whereas if you, that's what we do, but I don't do that privately because it's not a published research as such. It's just our practice. But I do see many patients return for a second. Because,
but why at 2 weeks?
I know, not at 2 weeks, because consultants will often want to review them and then decide whether a second is necessary. I often sometimes...
sorry, I've misunderstood.
Yeah.
So you give 2 injections.
2 weeks apart.
2 weeks apart?
As standard.
Okay.
But
there's no real reason for the 2 weeks.
Well, not necessarily the 2 weeks, but sometimes we do 4 weeks. But
okay, you just follow them up to have an injection.
Yeah, we want them up with a second injection.
Get it.
Within a short...
Do you know how I explain it in private practice? I'm a real stickler for getting that range of motion back.
Yeah.
So even though it looks as though you've got that foot forward flexion or the abduction, I know that actually if you're missing like the full glenohumeral joint range of motion, we might as well get it back. So even though I may not inject with another steroid and we just go for saline to distend it, it turns out I often do too. With those patients, because I just think when they are doing more complex upper limb movements, you'll just set up some dysfunction in the long term. And why not, if we can, with such a simple procedure, just get them movement back, if clinically indicated. So I do that. Less so with 2 steroids, but definitely with getting that range of motion, because I feel as though once the inflammation's gone, and this is just this again is not based on any research but more clinical intuition, because once the inflammation has calmed down,
it's about getting the
it's just about distending that capsule.
No, you're absolutely right. I mean, it's that hydrodilatations are interesting, aren't they, because no one quite understands why they work, because actually that fluid gets absorbed in the next few hours. But they do work. I mean, we see it time and time again. But interesting. But it's a nice win, because patients, the second time if they come back, they are so delighted because they've already had good improvement. So that's where I have some follow up. You obviously see them all after, Brinda.
No, and do you know what's really nice is that that was it. I pick up more and more really early adhesive capsulitis.
Yes.
Because I know this isn't your tendinopathy or your impingement. And and at times I'm trying to convince the patient and not look like I'm overselling them a steroid. And even though clinically I know what it is, and I'll give them a course of oral anti-inflammatories, but I know where the money is. And I say to them, look, I'm a pretty conservative doc. I rarely use steroids. But this one, I know it really makes a difference. So it's good to know that I'm still on.
I think more and more patients. I think more and more people are being picked up earlier, actually, more in that stage 1 when there's a lot of pain rather than all the restriction.
Yes, exactly. And it's the pain that starts.
Yes.
It's this pain like on lateral lying. That's why you can't get comfortable at night. They can't localise. Usually with tendinopathies, they can localise, pinpoint it under one fingertip. They're sort of vague about it. They're saying maybe it goes down my bicep, or they're using their whole hand. You know, that kind of pain. And that kind of pain pattern, you must clinically think... at least to send them for an ultrasound, and then from there hopefully they can get plugged into some hydrodistension.
I think it's increasing, and there has been now some research that's related to COVID, and COVID is according to some of the research, the inflammatory response of COVID has increased the chance of adhesive capsulitis, so we're definitely seeing more of it.
So even though we're 4 years out,
well, some of them, still since then, I would not say either people are picking it up more and referring more, or there is this residual effect. I mean, certainly COVID from its inflammatory effects is definitely, we saw quite a peak during the pandemic even. Increased number. But it's interesting that it feels like it's continuing. Thank you. So has that covered our GP point? Is there anything else you want to add to that? No, perfect. Then shall we move on to our third question? So what would you like to share with our specialist colleagues? So I think what would be nice to share with specialist colleagues is, so in imaging, we're getting technological advances. So now we have a fantastic sequence called the VIBE sequence. VIBE, V-I-B-E.
Okay.
I can tell you what it stands for, but no one will remember it.
Can I ask?
So it stands for volumetric, interpolated, breath-holding imaging.
Okay.
And it is being routinely used now in certain things. So, for example, it's being used for adolescent spines, where you're worried about pars fractures, particularly incomplete pars fractures, where they would have an MRI and then go on to CT imaging typically to look at the pars fracture in more detail. We can now supplement that with a VIBE sequence at the same sitting of an MRI, which is effectively looks like a CT image, actually. The cortex can be fully evaluated to look for those incomplete fractures. So that's one part of it. But the more important about it is that obviously there's not a radiation dose to adolescent spines. And when you want to follow these up for healing, after you've instigated some behavioural modifications or treatments, you don't have to do repeat serial CTs. You can do this VIBE sequence, which is
a sequence of an MRI.
Yeah, a sequence on the MRI, which I think has been fantastic, actually, because it really...
So it's longer, though, for the CT,
just a little...
Sorry, if you've got a fidgety patient, CT is quick, right?
Yeah, CT's quick, but they typically tolerate the MRIs,
patients.
and it's just a few more minutes for that sequence.
Okay.
So very part of the whole MRI.
Fine.
They probably wouldn't notice.
But as you were saying, for young spines, you don't want the radiation dose.
Yeah.
Okay.
And it's fantastic for its osseous anatomy. Whereas you'd have to say you might need to get a CT for that. Yeah. I think actually the VIBE is fantastic, and there's lots of research that's been done on it now, and it's routine for adolescent spines now for pars injuries, and we're seeing a lot more of these pars injuries. So,
do you want to talk about pars injuries? Because you're
no, not really. I don't really, but I like the VIBE sequences. So really, for the specialist, what I would say is, if you're getting an MR lumbar spine for an adolescent, or young
so this is just add on,
just right. MR lumbar spine plus VIBE sequence.
Okay, and
most
all
institutions will be doing
will
them.
have this. It's not a new machine. It's
no,
just a
not a new
sequence
machine. And most institutions will be offering it.
Okay,
I would say.
Okay.
And
private as well as NHS trusts.
Yes, I mean it's interesting. I think we see less of the pars injuries in the NHS. Interestingly,
right.
Often they go private. I would say, but those VIBE sequences are really important, and I think people should be aware of them.
Okay.
So that they can request them at the same time. Part of the same sequence.
Brilliant.
Saves another imaging cost as well.
Oh right, so you can't add it on after the MRI.
You could recall them for it. But it's part of the same package.
Get it? Yeah.
Yeah, you won't have to call them back for CT.
Okay.
Yeah.
Okay.
So
cool.
I think that's quite useful.
Okay, brilliant. Is there anything else you'd like to add?
I think you could use it for recurrent dislocators as well. Young patients who dislocate their shoulder.
Okay.
You can use it to look for that osseous Bankart lesion, because often people will dislocate their shoulder, and you can look at, for example, the labral tears, which you use for MRI, but sometimes they have a bony fragment that they've actually knocked off when they've dislocated their shoulder. And in those instances we often get a CT. But actually you could also add in a VIBE, say MR shoulder plus VIBE, if you're worried about that, and that should be added on. That's less routine, but I know that it can be done, and it's pretty good imaging on it.
Okay.
Yeah, but it'd be interesting to talk to your individual imaging departments to find out if they can do it. But I think it is added value.
Okay, that's the up and coming thing you want to share with the specialist.
That's my.
Thank you. It's coming straight from the specialist. Like you I'm a big fan of yours from when I was a registrar, and I used to sit in your ultrasound clinics. So thank you for coming. Thank you for sharing all your pearls of wisdom.
Thank you.
And you're spot on. 24 minutes,
Oh,
so I
really?
don't even need to edit this. Mwah! I can trust you,
Is that
Monica.
good?
Yeah.
Talk for 24 minutes. Amazing. I can always talk.
No, but it just shows, super efficient.
But you're a very good interview. You've got a very nice way, Brinda. I love that you're doing this podcast.
Thank you.
What's made you do it?
I hope it's useful. I mean, I can probably share this with you. So I see a lot of young patients, more so now in private practice.
Yeah.
And what I'm finding now, unfortunately, and I spend a good third of the appointment trying to explain to patients what their condition is, so I can get the mind-body connect. Because ultimately, what I'm offering them is physio and some painkillers.
Yeah.
And so if they haven't bought into my clinical diagnosis, because sometimes I won't get imaging, they're not really going to progress well with the treatment plan.
They have to. It's psychological as well.
Exactly.
Yeah.
But often I'm finding that half of that time I've allocated to explain things is undoing their expectations and unpicking their presumptions, because there's a lot of misinformation out there, especially with the generation, the age group that I'm dealing with.
Yeah.
And they've gleaned so much from social media and well-being types. And I definitely think this trend will continue. And you guys in the hospital will start realising as these patients age.
Yeah.
And so in a way, I know there are so many things that I say on repeat. And I know, I always talk about resistance training. You've got to get it in 3 times a week, more so if you're age 50 and over, because your muscle mass is rapidly declining. And they're not even sound bites, but there are things that I just say on repeat.
Yeah.
And there must be a more efficient way of putting it out there to promote health. And so that's why I just thought, I'm pretty sure most specialists, when they get into the sort of super specialty range, they only do one thing and they do it brilliantly. And they know how to spot it. And they know what it's not. And they know how to advise really quickly. And rather than allowing these social media types to take over, I sort of feel as though
we've got responsibility.
Exactly.
Yeah, there is
with
a
health,
sort of responsibility.
Health promotion and I think the thing is, and don't get me wrong, journalists do a good job. But there's a difficulty there because you don't know what you don't know. And so often when you've been interviewed by journalists, they'll say, oh, but can you tell me about the menopause or whatever's topical at that time, or mental health, and try and I'm just thinking, oh my God, there are so many more important messages to put out there. And I wish, we could be given that platform, but why not create our own platform? And so that's the idea. So hopefully these will be nice 20 or 30 minute recordings that people can listen to during their commute. And then also there was another reason, I do find it dispiriting when patients come and I don't think they realise actually how sometimes their tone is sort of like, oh no, but I want imaging, or I want this, or this is what I've requested. And it's almost as though they don't necessarily realise the level of expertise they're tapping into. And there's a turn of phrase, my GP knows nothing, which upsets me, even though I'm not a GP. I really feel for them, because I think that narrative needs to change.
It's interesting you say that, because I had a patient this morning. This is exactly this issue, and I had my registrar with me, ultrasound. And I could tell that the registrar had just requested like a 1/2 intermetatarsal bursar injection. Okay. And I looked at the MR and I was like, the MR's normal. It hasn't even been reported on here. Okay, let's see the patient. My registrar was scanning the patient. And then I said to the patient, I said, where is your pain? He's just scanning. Here, completely away from this one metatarsal.
Sorry, Monica's pointing to her ankle joint.
But I'm being recorded. And I had to say, I said, I really don't think that this is really the issue here. And I can see, and I went through all the imaging, bilateral knee MRs, lumbar spine, thoracic spine, all normal, but she's using a crutch. And I said, why are you using a crutch? To try and get a better understanding of the pain here.
You're going above and beyond.
And actually, she was very unhappy with me by the end. She said, I just came here for the injection and you're not giving me the injection. And I said, well, I'm just not sure that it's going to work. And she said, and you're quizzing me about why I'm using a crutch. And I thought that was very interesting, because I'm trying to look at the holistic
Yeah.
What are we really doing for you? Because what I'm doing is potentially, I'm giving you an injection which isn't without any risk, even though that's minimal risk. And she was very unhappy, actually. She said, I want you to put in the report that you've refused to do my injection. And I said, I haven't refused, but I am trying to discuss with you what the options are here. And I said, actually, I think you're a case to discuss in a multidisciplinary team meeting, because sometimes we work in silos, don't we? The knee people are working separate from the back people, and maybe we need to join this all up. But it was interesting that you say that people come with expectations, and if you don't deliver what they expect, even though you're trying to give them a better opinion, a more
experienced opinion. Honestly, it's almost, I don't want to go as far as saying that there's a lack of trust, but it's starting to have a tinge of that. It's like, honestly, I am trying to work in your best interest, honestly. I'll give you another example. So I'll often prescribe, a branded drug, because then I know that if it hasn't worked, at least they've had arcoxib, okay, not etrocoxib, and there are different versions and different fillers, and some people will vomit with that filler and not that, and I just want to cut through all of that and know whether you've responded to a tablet or not, because I need to escalate with your care. And this one patient got really upset with me and said, why are you pushing branded medication? And then it's not available in this pharmacist. And, she'd built up this picture that maybe somehow I was being bought by Big Pharma. And we laugh because it's not really a UK problem. It is an American problem from what I've heard. But, I give it for clinical reasons that are useful for me. And it's that level of distrust that I want. I want to reset the balance. Like I want the general population to understand often there's another narrative. And it's not just the narrative that you're being fed on, some online newspaper, tabloid site. I'm not saying it's not true, but there are other narratives. There's your narrative, there's my narrative, there's the media narrative. And on the whole, I think my colleagues are superstars in the fact that they just work really hard. And they're working on the whole for their patients. And I think that needs to be celebrated more. And I'm in a position now where I can hopefully raise a level of an awareness by speaking to my wonderful colleagues who were so generous with their time. I mean, Monica, it's like 8 p.m. on a Tuesday and you've popped over.
I've been
I'm not
invited
paying
to
you or anything.
My kids are like, what?
And that just speaks of everybody's generosity. They're like, yeah, okay. Nobody said no, which is just so wonderful. So wonderful. And for what? For what? I'm not offering them anything.
To see you as well.
I know, but it's lovely. It's lovely. So out of hours, you guys are hardworking and you've got kids that you've got to get back to. So thank you. So I hope that answers your question.
Yes, it does. It does. You're doing a good thing. Brinda, you're doing a good thing. And I really enjoyed listening to the one you sent me. I enjoyed it.
Okay, brilliant. Yeah. Okay, thank you so much, Monica.
Thank you.